Welcome to the Dermalorian podcast from the Dermatology Education Foundation. The Dermalorian podcast is made possible with support from Vitama, Tapinarof Cream 1%. To learn more about Vitama, please visit www.vitamahcp.com. That's VTAMAHCP.com. We're here live at Derm 2026, and I'm joined by DEF Advisory Council members and Derm faculty members, Alexa Hetzel and Andrea Nguyen. Guys, tell us a little bit about yourselves.
Thank you, Paul. It's my pleasure to be here. I'm Andrea Nguyen. I'm a practicing PA out in Southern California and part of the Dermatology Education Foundation Council.
Thank you for having me, Paul. My name is Alexa Hetzel. I am a PA. I practice in Central Jersey. Yes, it exists, Central Jersey. I am also a member of the DEF faculty, and I am the Director of Clinical Research at my practice.
Great. Well, thank you both for being here. Really appreciate it. So just wanted to catch up with you guys on some of the latest developments in dermatology. We've seen a lot going on really over the past couple of years, but in terms of new therapeutic advancements or some changes in the way that we're using therapies, what's top of mind for you guys?
There are so many new approved or expanded indications, and really exciting for us. Alexa and I were talking about this a little earlier. I mean, several pediatric expanded indications. We have risankizumab, which is Skyrizi, now FDA approved down for pediatric children. Also, we have the expanded indication for dupilumab or Dupixent for CSU patients with pediatric approval as well. Alexa, I don't know if you have some other ones who want to chime in on.
We actually have also guselkumab down to 6 as well, which is Tremfya for our psoriasis patients. And then we also have extended dosing for Ebglyss or lebrikizumab, where our patients could get it for every 8-week dosing.
Really exciting. I mean, this allows for not just treatment of patients, but also our younger kiddos. So when we have these approval indications for our young kids, some of them, unfortunately, you have to wait until they get older and we have limitations. And then also for our AD patients with Ebglyss and now being dosed every 8 weeks allows for a lot of injection, flexibility, which in my opinion, I think it allows us as clinicians to really tailor treatment as appropriate for patients and get that personalized touch.
Yeah, I think what's amazing about us as dermatology providers is we always want more, right? We're never satisfied. We always want the next thing, because how can we be more focused and tailored, like you were mentioning, to our patients? Because now we have a new oral peptide for psoriasis that's approved down to the age of 12 with icotrokinra or Icotide. That is not only a pill that you can swallow, but also a pill you can disperse in water. So for those 12-year-old patients, and I'm sure you've had them, where we're giving them antibiotics for acne and they're like, I can't swallow a pill. There is no reason now for us to not treat those patients because they have no excuse anymore.
Absolutely. I always have to kind of remind my patients, I mean, that's a great time. Not only do we have advancement in therapeutic options, we almost have a menu where we can offer patients, how would you like to get to whatever clinical control that you would like to for your disease? And that more than ever now, it's really amazing for patients. And for us, honestly, as clinicians, we are really superheroes sometimes in clinic because we're able to get patients to such high level of disease control, which really hasn't been, available until more recent years.
Absolutely.
I know one of the things that comes up sometimes is there is this sort of a split among parents that they have children with eczema and they're really suffering. They're not sleeping. They're distracted in school. We know sort of all the quality of life impact, but then they're a little bit reluctant sometimes to want to start a systemic therapy and something that they know is going to be potentially a long-term treatment. So how does something like these approvals and seeing the data in these younger ages, how does that support some of that conversation you need to have with parents?
I think as a parent myself, and you can speak to your experiences too, you never want something to be wrong with your kid, right? So it's a hard pill to swallow when it's not something you can fix. Like, mommy can kiss your boo-boos and it will be better, but that's not something that we can fix. So I always try to incorporate that I am a human as well when I'm talking to my parents of my patients, because they're equally involved in this decision making as the patient sitting in front of us. But also when we can say it's approved for the youngest of our kiddos at 6 months for some of these therapies, or 2 years for some of the topicals that we have. Lebrikizumab is trying to expand its age range down to 6 months as well. It just makes you feel more confident that this is safe, and it's the yin and the yang, right? The juice worth the squeeze, like Dr. Cohen loves to say. There will be potential downstream effects if we don't treat. Failure to thrive. Are you going to be diagnosed with ADHD? Are you sleeping? Is anybody else in the house sleeping? All of those things are also equally important to bring into conversation, not just the fear of what the treatment is.
I absolutely agree. And, in my area where I practice, there's a lot of discussion I have with my patients because many of the times they want lifestyle modification. They want non-alternative, non-therapeutic agents. And we talk about that. And definitely, there are things you can do that can improve your disease that are not prescription therapies. But sometimes it's not enough, right? And usually by the time that they wait and, come to see us and make appointments and schedule, typically that's because the disease is extensive enough that they waited several weeks to make an appointment, get insurance approval or something other to that extent. And so we talk about lifestyle modification. However, there are a lot of things to consider when you don't have treatment, right? If the child's not sleeping, unfortunately, that affects how they grow. Potentially for many of these patients, if you're not sleeping through the night, you can't concentrate in school. That might affect your academic performance. So really lotions and emollients are a really mainstay of therapy, but for many patients, it's not enough. You have to have that discussion with a lot of patients.
And you mentioned a new oral therapy for psoriasis. We have a couple options in the oral realm now. We had an interesting debate here at Derm 2026 talking about orals versus injectables. It considered a lot of options and was a little bit somewhat of a playful conversation. But I wanted to ask you guys, when you're in the clinic face-to-face with a patient, how do you think about that conversation?
I think for me, it's really now, like we said, we can customize and tailor sometimes what the patient wants. I have had patients that I have put on Icotide now that were so resistant to injectables before. And I didn't have the confidence to give them an oral therapy that I thought would give them what they needed. And so then they were just like, I'm going to stick on my topicals, I'm fine. And the reality is we weren't where we needed to be in terms of disease control. So as they've been filtering in for me, I am able and available to give them an option that I have confidence in that's not only going to be effective, but safe and available.
Absolutely. And it's really tailoring to personalized medicine now more than ever. And I'm surprised. Sometimes I have a discussion with a patient, I feel like they're going to go one way and they surprise me and they go the totally different way. And then by the next time they come in, maybe at their follow-up visit or even 3 follow-up visits later, the patient then feels different, right? So there's a lot. It's never a single size fits all. I think we always have to have that open dialogue with patients. But the real impressive, outstanding thing about how we practice today is that we actually have options. So this is actually something that's up for discussion because you have options.
You're listening to the Dermalorian podcast, made possible with support from Vitama, Tapinarof Cream 1%. To learn more about Vitama, please visit www.vitamahcp.com. So you just touched on something important. Patients do change their minds. And how easy is it to switch from an injectable to an oral or vice versa? I mean, this is something people, maybe they ask you at the start or they don't, and they come in later and say, hey, I want to switch, or they're already on something and there's a new option. So how does that process work?
Yeah, I love that. And it is, I always tell patients, it's all obviously not fun for me to go through the prior authorization process, but I'm there for you. If this is what you want, this is what we'll do. But these are the things that we have to consider, right? And for me, in the back of my mind, I always want to think of these diseases. Many of them are chronic diseases. So you're not going to take therapeutic intervention just once, right? It's not just one shot. It's not just one pill. So if we are going to pursue this, you really have to stick to something that you feel like you're going to be able to commit to. Now, if for whatever reason it doesn't work out, you have an issue, you have a side effect, life changes, your circumstances change, and we need to switch, obviously we can definitely switch. And typically that's based off of the medication, how often it's dosed, what else is going on with the patient, how active their disease is. But it's fairly, I find it fairly simple to switch them from one therapy to the other.
I agree with you on the prior authorization. That piece just is cumbersome in general, no matter what reason we're switching for. I think it does help if patients are failing their medication, then we can put that towards the next one. Hey, they failed this therapy. This is why we're looking at the next one. So hopefully it makes it a little easier. I have had patients come in though, and they're doing so well, they're perfectly clear, and then their friend says something, or they see a commercial that says, oh, I see the newest thing is out, should I try that? And for me, the answer is no, you shouldn't try that. You're doing so well. If you stop doing well, that's a different conversation, but if you're doing well, we're not gonna fix something that's not broken.
Yeah, and I love that you highlight that, because just because there's a new therapy out does not mean that we should switch. It's if the patient's not doing well. And why is that? It's because honestly, you're gonna have this disease typically while you walk, right? And I always think about, especially, I'm so traumatized by our prior therapies where we did see loss of efficacy, anti-drug antibodies, and you want to stretch these therapies out for as long as you can, especially when you deal with a younger patient demographic. So if you need to stop for whatever reason, pause or change therapy, that's totally okay, but we should have a valid medical reason for it, not just I saw a commercial and I want to switch. On the flip side, if you still have clinical disease, maybe you just have one small plaque that's, a thumbprint, that's driving you bananas. And some of my psoriasis patients, they'll have very limited disease on their scalp that they just cannot stop picking at. And even though the BSA is well controlled, we're at target, we're less than 1%, I offer those patients, do you want to do something else? Do you rather want to add on to your therapy, or do you want to switch therapies? Because if you're constantly picking at it, from a quality of life standpoint, I don't think that you're controlled. And we have therapies now that can give us excellent control. So why suffer?
Right, I think that's so valuable. And the other piece that I usually like to bring into when I see my patients for follow-up is how their joints are feeling. Because their skin may be completely clear, but their joints might start aching that they don't even necessarily realize. So that might be a reason why I may switch or add on therapy as well. Their skin might be perfect, but their joints are not controlled. And I can't reverse joint damage. I can make your skin look beautiful with anything, right? We have so many options, thankfully. But once that joint disease has progressed, there's a point of no return. So we want to make sure that we're asking about that as well.
You mentioned prior authorizations, and it made me think of a couple of questions. So one of them is, if you could just talk a little bit more about how some of these newer indications and these label expansions, how they allow you to prescribe, and how you might have to make sure that the insurers are aware of some of the decisions you're making based on the latest available treatments.
I find frequently with these expanded approvals or newer indications, sometimes the insurance systems are not updated in real time. So frequently when it's really hot off the press, I write to the prescribe. Some of the denials will say it's not approved, it's not an approved indication. You submit back the paperwork. Depending on the healthcare system, you still might hit a hurdle or might not. Unfortunately, I don't know if it's intentional or not, but these computer systems don't seem to sync up right with, real-time approvals. But you just keep fighting the good fight. I mean, I don't know if you feel differently, Alexa.
No, I feel the exact same way. I think what's good is all these companies usually have resources for us to put forward, right? There are articles that we can submit. There's clinical trial data that we can submit that helps kind of us fight this good fight. And then there are also samples too. So using samples in certain instances may be a way that we get them on therapy much more quickly as the insurance companies and these payers kind of get up to date. So then that way we're not missing too much time in treating them.
In the case of psoriasis, when we're talking about joint disease, for the patients that have it or that have symptoms, how do you go about if that's either you're changing a therapy or selecting a specific therapy because they don't just have skin involvement, but you're worried about the joints? How do you document that, and how does that sometimes affect the process of getting the patient access to that treatment that you think is truly best for them?
I mean, for me, I always have it as 2 separate diagnosis codes. I think that just shows that we're managing 2 chronic autoimmune conditions. So I think almost immediately that kind of is different things that AI can pick up on. Is the psoriasis diagnosis, but also the psoriatic diagnosis, a psoriatic arthritis diagnosis, not just psoriatic disease. And then I document my findings, whether it's the pain, where it is, if they have dactylitis, enthesitis. I have one patient, he couldn't wear his wedding ring, so I put that in. He literally had to have it cut off his finger. So those moments I like to include. But because I usually try to separate it that way, it's been a much easier process getting things approved.
Yeah. I do document for both psoriasis and psoriatic arthritis, but at least for me, I find I usually try to do the medical management under psoriasis, because some of the prior authorization referrals, at least what I get paperwork back in California, specifically under psoriasis, I still have a lot of leeway. Under psoriatic arthritis, sometimes they require it has to come from a rheumatologist or a rheumatology HCP. So I find I do document for both, but I put all of my medical decision-making in psoriasis. Now, I still screen aggressively for PSA. So I think that's a different consideration as a clinician. I'm always screening for PSA. I'm always looking for PSA. Even on patients that are stable and managed, I might see no skin lesions, but I still might have patients that have joint pain. And that I find that sometimes it changes. They might be really controlled last year, and then this year, all of a sudden, it's only, Andrea, I'm starting not to be able to surf. I'm starting not to be able to lift things. I'm feeling really stiff. And I don't see any skin lesions, but they have joint symptoms. And so in those, it's a little bit nuanced. Sometimes we talk about changing therapy. Sometimes we talk about adjunct therapy. Sometimes I refer to rheumatology and I co-manage. But I find, at least for me, I have a lot more gusto in paperwork when I do it under psoriasis. The good news for me, at least, and many of our colleagues, is we have excellent therapeutic agents that work for both. So you have indications for both. I can prescribe it for psoriasis, but I know I'm doing really well in the joints too.
My last question for you is, we've talked a lot about therapeutic developments, but one of the things that we talk a lot about at Derm is really supporting dermatology NPs and PAs in their careers and helping them be the best clinicians they can be. You guys were part of some panels and discussions about that. What do you sort of see as anything new or exciting just in terms of the opportunities that dermatology NPs and PAs have in 2026 in dermatology?
I think there's so many articles left for us to write. We still need to publish. We are being included in research more. I've become principal investigator on clinical studies, which hasn't been done before, and I am ready for everybody else to join me on that pedestal. I think there are more NPs and PAs that are actually going into pharma from an MSL perspective or a TLL perspective. There are a lot more opportunities available for us to kind of take care of the patient in multiple different ways. I don't know if you have any other experiences.
Yeah, absolutely. It's never been a better time to be, honestly, an advanced provider, a nurse practitioner, or PA. One of the things I've always really loved about this particular organization, this particular meeting, is that it really brings together a marriage of our two professions, really. At the same time, even though our licensure is different, even though our educational background is a little bit different, we see the same patients, we treat the same disease. So the educational content really should be the same for all of us, and we can all work together. This conference has really worked hard on giving a lot of clinical education for nurse practitioners and PAs, irrespective of your years in practice. So whether you're new in practice or experienced, but the one thing that has been a lot of fun this year is to see some of the workshops too, where we have like career development panels and discussion, and really talking about how you can evolve and improve yourself as a clinician, not just as a clinician, but also professionally, right? And so, like Alexa said, tons of new job opportunities. I agree. We have, journals that now allow us to publish, which is amazing, right? That's something that is much newer to our profession. And again, with many of these newer therapeutic options, there's just a lot of opportunity for us not only to excel as clinicians, but also in sort of peripheral positions regarding that, right? Whether it's in industry or in, as in the medical division, even as a PA or an MP.
If I can add one more thing, I think what's also so great about not only this meeting, Derm 2026 or Derm whatever year we want to insert, and the DEF overall, is that we are always all here to support each other. So if somebody is stuck and they're not sure, whether it's me asking you for help or another APP asking us for help, we are always here to be a good sounding board. And I think that's what's so special about the Dermatology Education Foundation, is we want everybody to succeed to the same level. So if somebody needs help or isn't sure where to go, we're here to help as well.
That's great. I completely agree with you. You can just see it here, the camaraderie and everyone sort of working together and supporting each other. It's wonderful to see. Thanks for joining us for this episode of the Dermalorian podcast from the Dermatology Education Foundation. Physician Resources produces the Dermalorian podcast on behalf of the DEF. We'll see you next time.